And we want to welcome you. And I'm going to ask people to mute themselves and encourage questions where you're welcome to unmute yourself and ask a question during the presentation. And thanks again very much, Dr. Halene, Stephanie, for speaking today.
Okay, so thank you, Diane, for this very kind introduction. And then thank you to everybody for being here this afternoon. I, of course, can't see anybody anymore because now I'm in full screen presentation and everybody's gone. Feel free to interrupt. I'll try and listen to voices saying like, hey, I have a question. I think it's a lot more fun if this is a conversation. And okay, let me just turn right. So I always dislike that our thank yous are way at the end when everybody's like, oh my God, I got to get out of this talk. So let me actually start with the thank yous. And definitely center of this presentation is Richard Lavelle, who with Marcus Manns really started this whole project with the humanized mice that we're talking about that have been really absolutely fantastic collaboration for my lab. And importantly, Anthony Ronveau is in the audience. And as you will see as I'm going through the talk, he really is the original Mr. G. And then Liang Shan, you will see, has done, I think, would say the foundational work for this red cell project. And then in my lab, it's Yeonbin Song and Rana, but with the help from everybody, Amisha Padma, Wei, obtaining samples, etc. And then, of course, also our pathologist, Diane. So a lot of people have contributed to this, and I think that's actually the amazing thing of the CCEHs is really a collaboration at institutions and across institutions, and certainly look forward to more collaborations. Maybe just for the trainees in the audience, I have to put in a few more basic things that maybe a lot of people, or most people probably already know. But why do we need in vivo models of human hematopoiesis? It really is that hematopoietic stem cells do not grow in culture and they cannot be expanded. So while we can put stem cells in culture, we're not really going to get any of them back out because they change in culture. It's just not the right environment. There really aren't any healthy human hematopoietic cell lines, right? All the human cell lines that are hematopoietic are in general leukemia. And then I think we all agree that mouse models, while amazing, and we can do a lot of really clean experiments with them, do not capture the intra or interperson heterogeneity. So mice are not women or men. And really, I think this is how this project started in Richard's lab, is that, you can also study other organ systems in the presence of a human immune system, and probably more important, as we recognize that the immune system can even cure cancer. That's why, so early on, when I was still in Diane's lab, I became interested clinically in myelodysplasia. Kind of knew that wasn't going to engraft and thought like, okay, these mice are got to be good. And that's actually when what Anthony was just talking about. Essentially, we met up in the basement in the mouse room to engraft these first mice, early mice. And, now that there's so many novel treatments coming to market, can we use these models kind of as disease avatars? Because, we can use one targeted treatment and another targeted treatment, but for example, can we use these models to combine them now that we understand mechanisms and we have so many more small molecules or combinations with immunotherapies, et cetera, that could be tested and then brought to clinic faster. And again, just mostly for the trainees, hematopoietic stem cells are maintained really by a balance of quiescence and expansion and also differentiation, where they give rise to all lineages. The daily production of red cells, platelets, neutrophils is just enormous, and that has to go on for the entire lifetime of a person. We know it can also, in sense of transplantation, supply a second person with a lifetime of these cells. So stem cells really have to be maintained very carefully. And the bone marrow microenvironment is complex. Just showing some pictures again from histology or from slides. So osteoblasts, osteoclasts, mast cells, endothelial cells, macrophages, fat cells, mesenchymal, stromal cells, these are in culture. So it's a very complex environment that is very difficult to replicate in a culture dish, as you can imagine. And this is just showing this in a different ways from a nice review from 2018. But again, these the hematopoietic stem cells really sit in this environment that has you know, a bunch of different cell types. So blood vessels are important. The osteoblasts, osteocytes are important. The neural system is important, and you know, and so you can imagine that if you could take you know, a human cell and put it into an environment that is already kind of preformed, for example, in another organism like a mouse, maybe you can replicate this easier and trying to do this in the culture dish. And so the question is, can you optimize the mouse bone marrow microenvironment for human cells? And here I'm just going, you know, using the review by Guillaume et al. From 2015, just to give a little of a perspective where these things started. So I think, and I was not part of those experiments quite a while ago. But you know, the first thing was to really knock out or get rid of adaptive and innate immunity in or adaptive immunity in these mouse models. And so those were kind of like the nude or skid or not skid mice, and different iterations. And they got rid of T cells, T and B cells. And then the not skid mice also maybe compromised the mouse macrophage function a bit. And then the early work showed that you could engraft, you know, leukemia initiating cells and identify leukemic hierarchy. And then the next generation, sorry, I have to move this thing around. Next generation then also sought to reduce innate immunity by reducing macrophages. And that's in the NOG mice or NSG mice, or the RAG gamma knockout mice with a human CRP alpha, which is a receptor for the don't eat me, CD47 don't eat me signal. And so these mice have absent T, B, and K cells, and also dysfunctional macrophages, and show increased engraftment and persistence of stem and progenitor cells, and transient survival of mature red cells and platelets in the peripheral blood. And you'll hear more about this. Oops, I was have a little thing there. So then, and this is again, Anthony should be giving this talk, but the Flavel lab, and I think together with Marcus Muntz, thought like, okay, can we further improve these mouse model, and thought about actually humanizing these mouse model, and to improve engraftment, get improved lineage maturation, improve cellular function. I think the ultimate goal was to have mice with a functional human immune system to study, for example, HIV, and actually also have, for example, circulating mature red cells, for example, to study malaria. And so one way one can further, improve the microenvironment via humanization is actually this model, the so-called BLT model, where one transplants fetal tissue into immunodeficient mice, so bone marrow, liver, and thymus. And I'm not going further into this one. And then Mark, I'm blanking on the name. Well, Wunderlich et al. So they actually they took these immunodeficient NSG mice and thought like, okay, there are certain cytokines that are essential for human hematopoietic stem cell or hematopoiesis, and those are stem cell factor, granulocyte macrophage, colony stimulant factor, and interleukin-3. And they actually generated so-called transgenic mice. So these are, expression constructs introduced into these mice, but the downside is that they are actually expressed in all cells, and they're not really regulated right through promoters, enhancers, etc. But what they did show is that these NSGS mice, as they're called, or SGM3, actually show improved engraftment of a subset of leukemias, and also maintenance of those. And then this is again where now Anthony Bongo comes in, and I think, Anthony, you gave me the slide. So Richard's group and Marcus Muntz actually looked very carefully at all the cytokines, and looked at, okay, which cytokines are essential for stem cell maintenance and cellular maturation, and which cytokines are cross-reactive or non-cross-reactive between from mouse to human, and identified interleukin-3, thrombopoietin, macrophage colony factor, interleukin-3, GM-CSF, and again here TPO as non-cross-reactive and important both for stem cell maintenance, but then also for differentiation of the different lineages. And then Anthony and Richard, Marcus, I think struck this alliance with Regeneron to actually not make transgenic mice, but to knock in the human allele into the mouse locus, so that the human cytokine would still be expressed in a physiologic manner. And that then led to this famous kind of Mr. G model. And so they used the RAG to receptor double knockout mice and introduced one cytokine after another. So human MCSF, 3GM are actually at the same locus. And then again, this is a beautiful work on thrombopoietin by Anthony. And then the latest addition was human IL-6 earlier on, the CERP alpha. And then this led to this Mr. G model initially, and published by Anthony in Nature Biotech in 2014. Mr. G was also the IL-6 published by Richard Labs and Madhav Dadkar's lab looking at multiple myeloma. And we were so lucky to be able to use the Mr. G mice to engraft MDS samples. So, so again, this is kind of comparing, these, I would say, three models that, humanize the microenvironment, so the BLT, again, the NSGS mice that have transgenic expression, and then the Mr. G mice that actually have physiologic expression. And what has certainly become very clear is that the NSGS mice are beautiful for some models and for some things, but because of the constitutive expression of these cytokines, hematopoietic stem cell are actually at advantage and actually lost over time due to differentiation, whereas Mr. G mice maintain hematopoietic stem cells. And again, this is from Anthony's paper, just comparing lots and lots of mice, but looking at fetal liver CD34 engraftment in either RAG gamma, the Mr. G mice that still have the murine CERP alpha, or the Mr. G mice that they have the human CERP alpha, and then comparing to the NSG mice. And as you can see, the non-skin gamma mice, they have relatively good human CD45 engraftment, and Mr. G mice are also in essentially in the same ballpark. But if you look now at what the composition is in the blood, what you can see is that NSG mice have really a lymphoid, B lymphoid predominance, and also leg and K cells. Whereas if you look at the composition in blood in Mr. G mice, you have very nice myeloid representation. You have lymphoid cells, T cells, and also NK cells, which resembles much more what the representation in patients or healthy humans. So let me just, again, since this is kind of like also a core talk, let me just mention a few technical aspects that we think about. So, when you want to engraft mice, right, you have to think about what your hematopoietic stem cell source is. And I think in general, we think about fetal liver, cord blood, and adult CD34 cells, and we think about adult, we can either get those from bone marrow or from mobilized peripheral blood. And all sources have, advantages, disadvantages. I would say that with fetal liver, there are a lot of people, who are concerned, they have ethical concerns. But if you look at the, for example, at the proliferative capacity, same number of CD34 cells are just going to give you higher engraftment levels when they're from fetal liver, and from cord blood in adult definitely have lower engraftment levels. There's also some lineage skewing, so in the output from these cells. So definitely what we and others have seen is that if you engraft fetal liver or cord blood, the output, you have a lot more erythropoiesis in the engrafted mice than if you use adult. I would say oops, hold on. Fetal liver and cord blood cells are definitely more immunologically naive. So less likely that you're going to get T cells that cause graft versus host disease. I mentioned the ethical concerns with fetal livers. And then, right, if once you want to model diseases, you obviously have to get the cells from the patients who have the disease. And definitely in my world, that is, for example, MDS, that is definitely the aging population. So, and it is cells from bone marrow, so very advantageous to have models that can graft adult bone marrow CD34 cells. And then the other question that we are asked a lot, in this core is, okay, what is the best way to engraft? And again, I think Anthony, you piloted that or spearheaded that in Richard's lab, is to actually engraft cells into intrahepatically, so into the liver of newborn mice. And I think that, and I'll show some images, that definitely has several advantages that I'll tell you about. The other, so this is into newborn or day 3 to 5 old mice. And then you can also engraft into adult mice. And there you can, of course, choose the intravenous route, the retroorbital or tail vein route, or the intrafemoral route. And there are definitely few experiments where things are done head to head, but then I think labs often acquire the technique that works for them for their disease. So if somebody wants to study a new disease, sometimes you have to probably do a head-to-head comparison of these different technologies. So we actually use a lot of engraftment into the liver of newborn mice. And this is just, so I believe Marcus Mans is the one who I think spearheaded this and showed that when you engraft cord blood CD34 cells into newborn mice, you actually have improved the novel generation and maturation of human dendritic cells, B cells, T cells, and he also found a broad repertoire. So it's possible that when you engraft into newborn mice, that you actually still have a thymus and you probably still have education of T cells. So we do this actually a lot, and this may look scary, but it's actually very, very successful, very safe, very fast techniques. So it's easy, we think, it's fast, and we're happy to teach. And Anthony actually taught me, and I passed it on to my lab members. What we also like is that keeping these mice is quite expensive. And if you engraft newborn mice, then you essentially have 3 to 4 weeks where your cells can now work in these mice before you have to go from one single cage to 2 or 3 cages. So I would say,
Stephanie,
yeah.
Apparently it's open for questions. This is Diane Krause.
Yeah.
So
Hey,
why do you do this approach rather than going directly in from the side to what you would know is the liver?
Yeah, so I think different people do it differently. So look, I have to say, Anthony taught me this way. I liked it. It works, and so I'm not changing it up. There definitely are people who go straight, with a shorter needle straight into the liver. So when you do it this way, you can definitely see the liver. You can see the tip of the needle then entering the liver. What I like is that you're right. It's like in patients, it's a tunneled catheter. So you're choosing a tunneled route, and so I could imagine that infection risk is less, bleeding is less, but either methodologies are fine. I think it's just learning one and then sticking with that one.
Thank you.
And thanks for the question. So, and then, right, when you do this, you always have to think, okay, when is a model successful? And also question we get always asked, when one publishes, you should never do that. But when one publishes, the question, of course, always is, well, do you just weed out the experiments where it didn't work and just show the ones that did work? And so we always try to really keep very clean track of, okay, how many samples did we try to engraft, and then how many did actually engraft, to give a fair representation of how well this model is working. And whether you use MDS or normal CD34 or leukemia, not all samples engraft, but ideally all samples would engraft. And that would be the best model. And then you also want to capture genetic heterogeneity. So, right, and I'll show the data, we try to inject at least 100,000 CD34 cells per mouse. Now you have to wonder, okay, how many either, MDS stem cells or stem cells are in there, and is only a subset of those going to engraft. And if you imagine that you have, for example, MDS, clonal, subclonal disease, are only certain clones going to engraft, and are you then really modeling the disease? So we probably have an opportunity there. It doesn't take a lot of money to get a bit closer at those answers by doing single cell DNA sequencing, at least on a subset of mice. You also want, of course, you would like to be able to maintain stem cells, which would then allow you to perform serial transplantation. And of course, one wants normal differentiation into all lineages. Ideally, these differentiated cells, then the moment they leave the bone marrow and migrate to their target tissues appropriately, and ideally any mature cells that are made should also survive. And I'll show you some data on that. So let me maybe skip over this because I'm just not sure about the timing. But again, the interest in my laboratory is MDS. It's a stem cell disorder, results in ineffective hematopoiesis, cytopenias, abnormal cell maturation, dysfunctional mature cells, dysplasia, and then genetic abnormalities and lots of different mutations. And so again, that was my clinical interest. And I had this opportunity to work with Anthony and Rongo and Richard Fabel to model MDS in Mr. G mice. And so again, we took the Mr. G mice and grafted newborn mice with hematopoietic stem cells, and then analyzed these mice 12 to 15 weeks after transplantation. So the first thing was, okay, and then at that time that we started this experiment, really the gold standard model were the NSG mice, so that was our comparator. Just one caveat here. So Mr. G mice or NSG mice are irradiated prior to engraftment. NSG mice only tolerate about 100 centigrades because of the DNA repair defect, whereas Mr. G mice tolerate higher radiation doses. And we chose different doses because we wanted to use an optimal model. So what you can see here, again, in red is always the kind of matched graft in Mr. G compared to NSG with the blue medium bars. And really across the normal samples, you can see that we get higher blood and higher bone marrow engraftment in the Mr. G mice of these normal samples. And then these are histologies looking at human 45, human CD15, which marks mature myeloid cells, human 68, which marks macrophages, glycophorin A, which marks erythropoiesis, and 61, which marks megakaryocytes. So cross-bank, we saw higher engraftment, and we saw maturation and better lineage representation. And then again, this is just showing kind of, again, as you had seen from Anthony's data, kind of the myeloid to lymphoid representation. So what you can see is that we actually with MDS are getting very, very, very few T cells. And then in general, MDS is quite myeloid predominant, which is also seen by other people. And then again, here we can see from this, again, these are all matched samples. In the Mr. G mice, you can see very nice representation of erythropoiesis, and you can also see the occasional megakaryocytes. And then this was really a huge feat done by Yamin Song with help from Rana, and Anthony's actually also on this paper. Yamin then took a whole bunch of different samples from patients with myelodysplasia, and there's higher grade myelodysplasia where there are more blasts, it's more aggressive disease, maybe more leukemia-like, and then there of course is low risk MDS, and low risk MDS had always really been the samples that nobody could engraft. And what you can see here, again, engraftment levels are not as high as when you have, for example, a lot of blasts, but you can definitely get engraftment of samples in Mr. G mice where you could imagine that you could study biology or test treatments. And when we quantitated this, so about half of the mice engrafted, half of the Mr. G mice engrafted myelodysplasia had engraftment levels higher than 10%, whereas only really a very small percent of NSG mice had such engraftment levels. And making this kind of a useful model, we think, to test treatments in biology. And then the other thing we also saw that, so because we didn't know what CD34 cell number would work, and also really just the nature of getting samples from the clinic, you just don't know what you get sometimes. And so we did not stick to a defined CD34 cell number, but really took, okay, these are the mice we have, and these are the samples we have, but we would always have a split donor graft into NSG and Mr. G. And what you can see here is that if we had more CD34 cells to engraft into Mr. G, we actually saw some sort of a dose response, whereas in NSG mice, the really engraftment levels were just universally low, and we couldn't improve those even by trying to engraft many more cells. And then if you want to model myelodysplasia, being able to model dysplasia is actually really important, and and also interesting, and also kind of an indicator that you're really engrafting the abnormal clone. And this is an example of a patient who had back then called refractory excess blast, or MDS excess blast 1. You can see here very dysplastic megakaryocytes, kind of like shown here by the reticulin, kind of reticulin fibrosis in this MDS, and these again are very abnormal looking megakaryocytes. And this is an example, like one of the Mr. T mice engrafted with his patient samples. And you can see that, it really, what we see in the marrow of the mouse really replicates what we see in the patient. And you can see here the staining of human MKs, and you can even see fibrosis. And these features are not present when Mr. G mice are engrafted with normal CD34 cells. And then lastly, we engrafted again a low risk MDS with refractory with ring sideroblast, very, very characteristic of SF3B1 mutant MDS. And right here is a patient. So this is actually an iron stain, and you can see these granules around the nuclei of the red cell precursors. Those are ironated mitochondria, and you don't see this in NSG mice, but you also don't really get erythropoiesis, where in Mr. G mice you do get MDS erythropoiesis engrafted, and you can actually see these ring sideroblasts. So just telling us that these mice are permissive to defective human hematopoietic stem cell engraftment, and then also differentiation. So supportive, maybe more open niche. And then what we also did is that we then took the bone marrow from the mice and sequenced to look whether we were engrafting the mutant clone. So we now kind of have quite a good understanding of disease progression, where there's this entity of clonal hematopoiesis. Then patients develop cytopenic dysplasia, so MDS, and then eventually the disease progresses. And this goes along with the acquisition of additional mutations. And this is comparing sequencing in a patient versus engrafted Mr. G mice. And we had sample from the patient both with initial MDS diagnosis and then with progression to secondary AML. This is showing that both in the Mr. G mice and in the patient, we can detect this the DNMT3A mutation this patient was carrying. We were able to, even in the MDS engrafted mice, to see the IDH1 mutation this patient was carrying, whereas this kind of was initially hiding in the patient, but then very evident in secondary AML. And then in the Mr. G mice, we then have engraftment of this NRAS probably subclone that led to progression to secondary AML. And then I was talking about the importance of maintaining stem cells, and one of the measures is whether you can take now bone marrow from the primary engrafted mice and engraft it into secondary recipients and then still find human cells. And so we did that for a subset of these samples. This is a bit complicated, but here you can see the bone marrow engraftment levels of this MDS-EB1 sample in NSG mice, in Mr. G mice. This is a logarithmic scale, so you see nice engraftment levels. And then these were then taken and engrafted, again, each of them into NSG mice where you have very low secondary engraftment levels, or into, we took the NSG and grafted them into NSG, the Mr. G into Mr. G, and you can see persistently high engraftment levels, though there is a reduction, but we also engrafted not just 1-to-1, but from one mouse to several mice. And then we verified via sequencing that we would still, right, these were, so what you can see here at the x-axis in both these is the variant allele frequency for the mutations identified in the patients. And then these symbols represent the different mice, either primary recipient mice or secondary recipient mice. And you can see a good correlation between the patient's varying frequencies and the engrafted mice, suggesting that we can, that in these mice, we can engraft the mutant MDS and also subclones. So then from here, we wanted to determine, is this a useful model? Is this just, okay, we can do this and we can engraft these cells, but can we also use it to model treatment response? And here we focused on IDH mutant MDS, just for those who are not familiar with this. So isocitrate dehydrogenase 1 or 2 mutations result in conversion of alpha-ketoglutarate into 2-hydroxyglutarate that then inhibits alpha-ketoglutarate dependent dioxygenases. And those are, for example, histone lysine demethylases, the TET enzymes, or RNA demethylating enzymes, and many, many more. And this 2-HG or 2-hydroxyglutarate is essentially called an oncometabolite because it is known to contribute to the MDS or AML disease pathology. And Agios and then Sajin developed a very specific inhibitor of specifically the mutant enzyme and not the wild type enzyme called AG221 or inacitinib. And back then, when we were doing this, these agents were actually in clinical trials. And so we were able to have inacitinib synthesized and tested it in IDH2 mutant MDS engrafted Mr. G mice. And this is comparing either vehicle treated mice or inacitinib treated mice pre and post treatment. And again, from a technical aspect, the way we do this is that we engraft the mice, and then around 6 to 8 weeks, we check for engraftment in the blood. If we can see, okay, these mice are engrafted, we would then perform bone marrow aspiration. And that is our, our pre engraftment levels. And then because you can see that there's heterogeneity between, engraftment levels, we would then stratify the mice so that we would have equal representation of engraftment levels in both vehicle and drug treatment, and then treat the mice for 3 to 4 weeks and determine then engraftment levels afterwards. And you can see nice reduction in engraftment levels with inacitinib. And you can also see a reduction of the 2-hydroxyglutarate in the plasma. And then what had already been described from clinical trials was that one of the mechanisms how inacitinib works is that it actually results in differentiation of the mutant clones. And that is something that we could see in these Mr. G mice, again, because Mr. G mice have cytokines that are essential, for example, for myelopoiesis. So you can actually, cells are able to differentiate in these mice. And so you can see here inacitinib treated mice have, for example, human CD50 in the marrow, whereas vehicle treated mice do not. And you can also see lots of megakaryocytes. And it is known that most patients actually maintain their mutant clone, and mature neutrophils in patients are, for example, IDH mutant. And so until this point, we had replicated what is known. Okay, inacitinib works in IDH mutant MDS, but could we also take things into a new direction? And animation that doesn't quite work. And so we were already collaborating with Ranjit Bindra and Peter Glaser at Yale, who had determined that in IDH1 mutant glioma, that IDH mutations actually result in a DNA repair defect. And they found that similar to BRCA mutant cells, oops, how do I go back? That IDH mutant cells are actually exquisitely sensitive to PARP inhibition. And what you can, just briefly maybe on this model, what you can see here, these are cells that are either expressing wild type or mutant IDH, sorry, the cells are expressing mutant IDH1, and they are treated with this Bristol-Myers Squibb PARP inhibitor, and you can see that the mutant cells, so the mutations induced with doxycycline, are actually sensitive to the PARP inhibitor, whereas wild-type cells or mutant cells treated with inacitinib, so where you now make this 2-HT go away, are no longer sensitive. So the 2-hydroxyglutarate results in sensitivity to PARP inhibitors. So we wanted to test that in primary MDS. And this is work done by Yamin Song and Rana Shvili, again in grafted Mr. G mice, comparing, so these are two different samples. They are both IDH2 mutant, and they engrafted mice, again, performed bone marrow aspiration, treated the mice, then euthanized the mice for analysis, and treated them with either a vehicle, inacitinib as a control, or olaparib, so this PARP inhibitor. And you can see that whereas in vehicle, the disease progressed, both inacitinib or olaparib successfully treated these mice. And this is just a second sample. Whereas when they engrafted wild-type IDH2 wild-type MDS AML, the olaparib treated mice behaved just like the vehicle treated mice. And then in a third experiment, they engrafted actually IDH inhibitor resistant cells. So those cells, it is known that some of the resistance mechanisms to the IDH inhibitors are, for example, via isotype switching or via second site mutations in the IDH protein, making them resistant to the IDH inhibitors. But the cells would actually resume producing this oncometabolite 2AG, a kind of mechanism of metabolite, oncometabolite dependence. And so these cells should still be sensitive to the PARP inhibitor. And that's what they did here. So this is a patient who originally was IDH2 mutant and received IDH inhibitor and actually responded to IDH inhibitor. So this is the pre-treatment patient sample. And as you can see, even in the mice, we can model that. So this sample is sensitive to inacitinib and to olaparib. But then when they engrafted the sample post-relapse after inacitinib, now inacitinib no longer works, behaves just like vehicle, whereas we can still see some effectiveness of the olaparib. And yeah.
This is Diane Ward. If you'll go back one slide, I'm just curious, mechanistically, are there synergistic or antagonistic effects of the two compounds?
Yeah, that's a very interesting question. So at least from the cell line, from the cell line data from the studies Ranjit has done, so the PARP inhibitor effect depends on the 2HG produced by the mutant cells. And so if you use inacitinib, you inhibit the mutant IDH proteins and you don't make this 2HG. So they should be, and in his cell models, he shows that if you treat the cells with an IDH1 or IDH2 inhibitor, the PARP no longer works. The PARP inhibitor no longer works.
Okay, thank you.
Yeah, and this should be relevant, in the clinic. Now there are going to be a lot of combinations, of inacitinib or ivosidenib with all sorts of medications and the question is, well, like cytotoxic or maybe venetoclax. Are those actually more effective in IDH mutant cells because of this DNA repair defect? So it'll be very interesting to see whether that can be teased out in the clinic. So Ranjit's recommendation is, oh, don't do that. Don't choose those combinations. But
But
time will show. Time will show.
You have the mouse where you could test those in the mouse first.
We can. But again, it's a model. So the truth will always be in the patients.
Sure.
So yeah. And
but it could be really informing as a first pass.
Yeah, absolutely. Yeah.
Thanks.
So there is now a trial going on that's run by Thomas at Yale and other institutions through the ETCTN network. And that is now looking at patients with AML or MDS who are IDH1/2 mutant, and several arm, lots of precautions, treatment, and so that because of COVID, that was very, very delayed, and so this is just about to start. What we do think is that single agent therapy is probably not going to cure anybody with MDS, and so what we're very interested in pursuing from here really is combination therapies in these mice. And that's those are kind of our next steps that we're embarking on. And hopefully we'll learn some good things out of these trials. Okay, so so maybe let me just, in the interest of time, go over this because I think I said all of this already. So the first summary. So what again, as a hematologist, right, we always look at the blood first, and then the blood tells us what's going on. For example, do we need to do a bone marrow? What disease does this patient have? And and I think when you study mice, right, we also get CBCs and we do flow cytometry for blood. But when you think about even the humanized mice and grafted with human cells, the human cells are, at least the myeloid cells, are always absent in the peripheral blood, and in particular, human red cells are just absent. There's no mouse models today that have human red cells in circulation, and so why is that? So so this is, again, I think, a project years in the making. I'm sure Anthony has played a role in it, and then Liang Shan, Strovic, so a lot of people in the Favela lab. And because we were working together, and as a hematologist, this has been super, super interesting to me and to my group too. And so this has turned into a really awesome collaboration. And so this is really work done by Yambin, Liang, and so on. But what they did is first to look at, okay, what happens to red cells in these mice. And so they injected fluorescently labeled, so with different colors, human and mouse red cells into the Mr. G mice, and then determined the ratio of human to mouse. And what you can see is that, so these equal number of red cells injected into the mice and then just flowed at very close intervals. And you can see that human red cells in the mouse very, very, very rapidly disappear. And then one thing Liang did was to like, okay, where do the red cells go? And he did the same thing, injecting both human and murine fluorescently labeled red cells, and then analyzed the ratio of human to mouse in all tissues, so in blood, which I just showed you, lung, bone marrow, spleen, and liver, and then kind of just looked at the ratio. And what he saw is that, well, a lot of these human red cells seem to get stuck in the liver. They're also in the spleen, and as clinicians, we always think about the spleen destroying red cells and autoimmune hemophilia, etc. But Liang was particularly intrigued by the liver, and maybe also because in mice, and that's still true for the Mr. G mice, the spleen really is the site also of murine stress erythropoiesis. And I think the moment you replace the bone marrow with human cells, the mice still need their murine red cells. So maybe messing with the spleen also wasn't really going to be such a good idea. And so Liang thought, okay, can you visualize the red cell flow in the mouse liver? And so this is now Mr. G mouse injected with fluorescently labeled urine red cells. And if you just focus, on like these yellow circles, you can look everywhere. You kind of can see these red cells just race through the liver. When he did the same now with fluorescently labeled human red cells, it's a bit of a different picture, and you can see that the red cells really seem to get stuck, right? You can suddenly see a lot of them in these, kind of dots, suggesting that human red cells are getting trapped in the mouse liver. And so this is not a new model that they invented. So these FAH knockout mice were already known, but so there is actually a way of humanizing the mouse liver, and for that one can delete this enzyme, which I call FAH, but it's fumaryl acetoacetate hydrolase, and essentially it creates a metabolic defect in these mice. And so you have to give them special water to prevent accumulation of the toxic metabolites in the tyrosine metabolism. And when you take these mice off this so-called NTBC water spelled out down here, you can then, and you kind of cycle them on off this NTBC water, you can induce very controlled murine hepatocyte damage, and you can then inject human hepatocytes via the splenic vein into these mice. These human hepatocytes populate the liver, and as the murine liver cells get destroyed, the human hepatocytes can repopulate the liver. So, and these are now these so-called Mr. G FA mice. And one way you can now track whether you actually have human hepatocytes, you can just measure human albumin in plasma. And so these are now mice, I believe, circled like 8 to 10 weeks off, NTBC water after injection of human hepatocytes, and you can see that you can now measure the human albumin. And when you then perform histology on the livers, you can just stain for the FAH because it's knocked out in the mouse cells. So these are mouse cells, they're negative, and any hepatocyte that is FAH positive is actually a human hepatocyte. And now you can repeat the same experiment. You can take a mouse where the liver is humanized, and you can inject fluorescently labeled human and murine red cells into mice that where the liver was either replaced with murine hepatocytes or the liver was replaced with human hepatocytes. And again, this is a logarithmic scale, so it's, it looks quite good, but again, it's a logarithmic scale, so you still definitely have red cell destruction in the human liver mice, but it is much improved compared to the murine liver mice.
Stephanie?
I'm suggesting that now. Yeah.
Oh, there's a question from Hal Broxmeyer, which is, in the Mr. G mice, can you remove the spleens? And if so, does that help with the red cell problem?
Yeah, we had that discussion. So I believe, and I don't know if Anthony did the experiments, but I believe Tilstrovic tried that, and it didn't make a difference. And the other caveat I would bring up is that, again, it's a site of murine stress erythropoiesis, and if you do get high engraftment levels of human cells, that also then make functional human macrophages, which is particular to the Mr. G mice, the human macrophages do eat murine red cells. So the spleen is probably really important for the longevity of this model because you are going to have murine stress erythropoiesis. So, yeah.
Thank you.
So then the next question was, okay, so can you now take these mice that have a humanized liver and engraft human CD34 cells, and then what do you see, right? And the ultimate question, can you then get circulating red cells? So we were a little bit surprised that these humanized liver mice with the same cell number seem to have higher engraftment, and they also have higher erythropoiesis in the bone marrow. And then, but importantly, we actually do see circulating human red cells in the peripheral blood of these mice. And these are persistent. So, right, there are mouse, people have done experiments where they have injected liposomal clodronate to get rid of the murine macrophages. And then people have seen a very transient kind of blip of human red cells circulating, but it's transient and it's generally quite low. People have also, for example, injected like cobra venom to get rid of the murine complement and have also seen small blips. But to have really persistent human red cells circulating has really not been shown before. So this was very exciting. So then, of course, the question is, okay, why does it work? And then, one thing we did was, okay, so what factors are made in the liver that could be very important? And probably the most obvious is that complement is made in the murine liver. But if we humanize the liver, the murine complement drastically drops. And we can then also stain the bone marrow, human bone marrow erythroid precursors for C3. And if you have still a murine liver, all the erythroid precursors in the bone marrow essentially stained, coated with murine complement 3, whereas in the human liver mice that is absent. And then we also looked at kind of macrophage composition in these livers. So again, on the left are the murine livers, on the right the human. At top is staining for F480, so for murine macrophages. At the bottom is staining for human CD68, so human macrophages. And right, we do get human macrophages in both the murine and the human liver, but we get a lot fewer murine macrophages. And I think, I'm not at all a liver expert, but I think in the liver, you can have resident macrophages, but you can also recruit, macrophages right from the bone marrow. And it's what we suspect is that by turning over the liver cells, that maybe the recruitment of urine macrophages is reduced, and instead we have more human macrophages. So
another
yeah.
question from Shilpa, which is asking, do you see any mouse macrophages in the human erythroid blood islands in the engrafted bone marrow?
Yeah, I'm not showing any of the image stream. So, but we do kind of see all sorts of compositions of blood islands. So human macrophage with just human erythroid precursor, or human macrophage with both human and mouse, murine macrophages with both, murine macrophages with just murine erythroid cells. So, one thought we had, could we potentially try and sort these out and then look at, okay, are those different types of macrophages? But we haven't looked at that more closely.
Thank you.
And so then, again, as a hematologist, and also a hematologist who does not just see patients with malignant hematology, we were really interested, okay, can we model sickle cell sickle cell disease in these mice, just because it's a disease that is driven by the abnormal red cells. And so we engrafted 2 samples for 2 patients with sickle cell disease, both hemoglobin SS disease, into these mice, and then age matched healthy bone marrow. And here, this is just showing engraftment levels that were very similar between the normal and the sickle cell disease marrow engraftment. Both have erythropoiesis, and then we do see, it's all the cells are mutants, so all the cells that are engrafted have the sickle cell mutation. And then the big question we were asking, okay, can we see vaso-occlusion? Because you would, when we have patients with sickle cell disease, if we can transfuse them and get their sickle red cells down to less than 30%, we say okay, now they're fine, there's no more vaso-occlusion going on. So if we only get maybe 10% circulating human red cells, would we still see vaso-occlusion? So one thing to remember, again, for the trainees, human red cells are about twice the size of the murine red cells. So size may be, on our side, maybe in making sickled human red cells worse in a mouse than they would otherwise be. But Ben took tissues from, again, the mice engrafted with normal versus sickle cell bone marrow, and and these are all with humanized livers, and then just stained them for a human-specific anti-hemoglobin A antibody. And so what you can see here is that in spleen, lung, liver, and kidney, you can see very few human red cells in these tissues. But when you look at the sickle cell CD34 engrafted mice, you can now see that these red cells, are in the glomeruli, and in the vasculature. They seem to be clogging the hepatic sinusoids. They are in the lung, causing obstructions of vessels. And again, that's hard to see here, but in the spleen is more of a mixed picture, where these are also still nucleated cells, suggesting that some of the human erythroid precursors are going to the mouse spleen, which would be another interesting thing to think about. So, so just a summary too. So, Mr. G mice are ideally suited for preclinical studies of MDS-ML. Human red cells get normally destroyed by the mouse innate immune system. The mouse liver is, let's say, a major site of human red blood cell destruction, definitely not the only one. And liver humanization prolongs survival of transfused human red cells and enhances bone marrow human erythropoiesis, which will still be kind of an interesting aspect to think about. It eliminates murine complement, allows replacement of murine with human Kupffer cells, and allows modeling of human erythropoiesis and diseases thereof. So this is the mouse I was talking about. Yeah.
Can I ask a question about when you just showed those slides of where the human cells were? Why do you suppose the lung and the kidney don't have 10% human cells? I mean, they have a lot of vasculature. Why wouldn't you expect, especially the kidney, shouldn't those glomeruli have like 10% human red cells in it? I would expect to see more in the normal, right? The normal is still a who had Mr. G, right? With human cells in it, or is the normal just normal mouse?
No. So that's it's a Mr. G mouse, humanized liver, and engrafted with normal CD34 cells.
Yeah, so shouldn't you expect to see human red cells in the liver and kidney? There's so few, it's way less than 10%, right? I would expect to see 10% at baseline and then see accumulation.
Yeah, so yeah, I think I see what you mean, right? So I mean, obviously, right, all the cells we're looking at, none of these cells are really hematopoietic cells we're looking at, right? So these are the kidney cells, right? These are the tubules, these are the glomeruli. And
right, but you don't expect the lung to have blood throughout it either, right? So some of that must be vasculature. So the fact that I would expect the kidney being so vascular that I would see some, more human red cells.
It's true. Yeah, I mean, I would, and I'm trying to think how to explain. It's a good question, right? I mean, if we look at, right, if you think of looking, right, if you look at just a human kidney, right? Although never mind, we never stain with anti-hemoglobin A, but if you look at H&Es from kidneys from patients, right? The vessels aren't all filled with red cells, you know what I mean? So I'm not sure how.
Oh, maybe this slice isn't very vascular or something.
No. I'm not sure, how, like, even if you were to stain all human tissue with anti-hemoglobin A, right, blood, right, it also flows out, right? I mean, when you take these tissues bleed. So I honestly don't know how many, red cells kind of stay in circulation in the vasculature, right? And I think the reason we are seeing the cells in the liver and the kidney, because they're actually stuck. I think they're causing vasoocclusion, right? So they're not removed by the processing and so on.
Right. But I would want to know that it's not because of their impact, the processing impact on them, and because they're actually vasooccluded in vivo, right? That's what I would want to know, right?
Yeah, no, but I mean, right, so the tissues were all processed the same way. And I'm showing you here exemplary slides, but we have slides essentially from all the mice. And we see this consistently across all the mice. Yeah, no, you're absolutely right. So, when we initially saw this, we're like, okay, what is this artifact or so? So I made Jan Bin stain a lot of the mice, and this is kind of persistent across the two samples.
Yeah, thanks. I don't
So
want to take up too much of your time. Yeah.
No, that's fine.
I just have one question. This is Diane Ward, and this is completely different question. So because you humanize the liver cells, is that suggesting to you that it's something about, and you did the metabolism piece, but is it something on the liver cells that's recognizing the human RBCs? I'm just trying to understand mechanistically what's going on there.
Yeah, I don't think we know all of it. I don't think we know all
because you can fix
that
it
is
by
doing
putting
that.
human hepatocytes in.
Yeah. So, right, I think the big questions are, okay, when we replace with human hepatocytes, we engraft C34 cells, are there any other hepatic structures, that are potentially getting humanized? Hepatocytes, I mean, there are scavenger receptors, there are other things. I think we're scratching the surface. So, and we still have destruction of red cells. So this is not like, okay, now it's perfect. There's still cell turnover. We still have the spleen that is still, a mouse spleen, still a mouse reticular endothelial system.
But your data really suggests that it's something about the hepatocyte, right? Because you can rescue by providing human hepatocytes.
Yeah, they're definitely doing something.
Yeah.
No, we don't have all the answers. No, I think this is actually it. And I think we're already a little past the hour. So again, I just wanted to say, right, so one thing about these mice, of course, is that they were made by Yale, HMI, and Regeneron, which has held up really their distribution. But these three entities have, I think, finally found an agreement. And so there is an agreed upon simple MTA for investigators. And the mice should be on their way to Jackson Lab. So all the published strains should be making it to Jackson Lab. And I know the ones that are definitely on their way are the Mr. D6. And so what we're recommending, and I can maybe unshare now, what we're recommending to people is email Jackson Lab and if you're interested in having these mice, get on their list so that they expand out their colonies when they get them, so they're able to send them out.
Okay. I have one more comment from Hal Broxmeyer, which is in response to your answer to his question previously about spleen removal. He said, thank you, I understand your comments, but would spleen removal allow for higher engraftment of myeloid cells in the bone marrow and blood, at least in the shorter term?
Yeah, it's definitely something we could try and do again. I think, again, I believe when Till did it, it didn't really give him a lot. Could you potentially do that now in these mice? It could be something that's worth trying. Yeah, as it is these humanized liver mice, it's a feat to make them. So.
It sounds like it. Great, thank you. Anybody else with questions, please chime in. See, Anthony, do you want to ask your question or do you want me to read it?
I can ask it. So you've improved your red blood cells from essentially nothing to a few percent. What's your hypothesis and what do you think is needed to now reach percentage of human red blood cells from which the mice could survive without the mouse red blood cells? You did not mention EPO. I'm sure you've tried to humanize the Mr. G.
Not I, but your colleagues. I think people who have injected erythropoietin haven't seen a big difference. I think the erythropoietin knockout mice don't survive. So you have to maintain it heterozygous. So, you know, I'm not sure that you can get to 100%, you know. I mean, we've never tried that, you know. I mean, there's, I guess, a lot of things you could try, right? You could try and maintain a mouse ICU, you know, by transfusing mice with human red cells for a while and see whether they can really survive on it. I don't know. I'm not sure that it's possible. So I think we have to be happy with what we can get. I'm quite amazed that we can get vaso-occlusion with, you know, levels of around 10%. But there's still a lot of work to do. Anthony, you have thoughts of what we should do?
I would argue that there's a huge role of the macrophage, and that's why I asked that question about the, I think that if you get 100% human macrophages in human blood islands, I think you can get a lot higher percentage, but I think the mouse macrophages are interfering with the distribution.
Yeah.
I mean, unless they can compensate, unless they can provide iron or they can push a nucleation. But I mean, all of our in vitro systems can't get a nucleation to 100% because of the lack of macrophages.
Yeah, these red cells are nucleated. No, you're right. And we have tried to inject these mice with a CCR2, anti-CCR2 antibody, and saw also, right, a little bit of an increase. That was not the humanized livers, a little bit of an increase in human red cell survival. So, right, but I think, right, there are mice that are, what are they? They're CSF1, the OP mice knockout, and right, and they have their own big problems where they don't develop teeth and because of lack of osteoclast differentiation. So, yeah.
I can't remember the postdoc in Flavel's lab who was working on this when I was there. I feel like he did that EMP knockout briefly.
Yeah, I think.
And that actually raised the red cells as well. That was like to prevent the interaction between the mouse macrophages and the human erythroid precursors.
Yeah.
What was his name?
Yeah. Liang.
Liang, yeah, that's right.
Yeah.
We have one more question in the chat. Lev, do you want to ask it?
It's fine. Hello, Stephanie. I just wanted to ask, very nice talk, hello. I just wanted to ask if anyone is trying this non-irradiation based conditioning in these mice? Because in theory, CD45 should be the same, right? Or kidney, you know. It'd be nice to see native microenvironment in these animals as well.
Yeah. So, right. So I think, again, and Anthony tried that. So I think you can engraft into Mr. G mice without irradiation. You just get lower levels of engraftment, but you get more than you would get in other mice. And that's probably right because of all the humanizations. You don't just have human cytokines, you're lacking murine cytokines, you have a defect. So the next version of these mice that we're actually working on, we introduced a c-KIT mutation into the Mr. G mice, right? So that's a stem cell factor receptor mutation. And we have done some engraftments into them. And so you can engraft, I mean, you know, and Claudia Vaskov has shown that in the NSG mice that are very nice, right? Where you can engraft without irradiation. And so we have now the Mr. G with the interleukin 6 and the KIT mutation, and just have to do some head-to-head testing on them.
Right.
So I have to admit, we were trying to think, okay, these got to be amazing mice. And we tried Fanconi anemia, and that has turned out to be incredibly, you just don't get enough cells.
Right.
So, you know, there's always higher stars we can try and reach for.
Sure.
So we have to characterize these mice now. Yeah, but it could work.
Okay, excellent. Thank you.
Okay, great. Thank you for a wonderful talk and some really cutting edge technology development that's going on clearly there. We appreciate everybody's attendance. I want to encourage you again to go check out the CCEH.io website if you want to learn more events that are happening at the CCEHs, and please feel free to share this with your colleagues. And also take a look at the funding opportunities that are periodically populating there to fund pilot and feasibility projects for you. And thanks again, and we'll see you in a month. And thank you again, Stephanie. Really appreciate it.
Thank you, Diane. Thank you, everyone, for
everybody. Take
hanging
care.
in there.